Welcome to today's webinar, Building and Financing Sustainable Partnerships Between Healthcare and Community-Based Organizations. Before we get started, I would like to go over a few items so you know how to participate in today's event. When you joined today's webinar, you selected to join either by phone call or computer audio. If for any reason you would like to change your selection, you can do so by accessing your audio pane in your control panel. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time, and we will collect these and address them during the Q&A session at the end of today's presentation. I would now like to introduce John Feather, CEO of Grantmakers in Aging and moderator for today's webinar. Go ahead, John.
Thank you, Clara, and welcome to all of you. Before we get started today, I want to thank the John A. Hartford Foundation, whose ongoing support for this Conversations with GIA webinar series allows us to offer these webinars to all of you free of charge. There's a newly released report from Meals on Wheels America and Quantified Ventures that was supported by Nonprofit Finance Fund, which is called Effective Partnerships Between Community-Based Organizations and Healthcare, a Possible Path to Sustainability. And it describes what we're going to be talking about today, which is a first-in-kind attempt to develop a pay-for-success project between a Medicare Advantage plan and Meals on Wheels America. The project resulted in the Medicare Advantage plan paying for the Meals on Wheels services directly, bypassing the need for a pay-for-success approach. The process of methodically structuring the Pay-for-Success project led Meals on Wheels to build the trust and confidence with the Medicare Advantage plan required for such a direct contract, which is the main goal of Pay-for-Success. So we are pleased to have our two speakers with us today who are going to help us with that process. With us are Lucy Teilheimer, who is the Chief Strategy and Impact Officer at Meals on Wheels America. Lucy is responsible for strategy and planning, research, and efforts to improve organizational efficiency and effectiveness. Prior to joining the association, Lucy served in multiple roles at AARP. Most recently, she was Senior Vice President for Organizational and Management Effectiveness, and prior to that, Senior Vice President for Enterprise Strategy. She also has many years of experience in aging, healthcare, and long-term care at AARP, as well as other health and aging nonprofit associations. Brendan O'Connor is Director of Business Development at Quantified Ventures and also brings a deep healthcare consulting, project management, and advocacy background. Prior to joining Quantified Ventures, Brendan was an associate at Townsend Consultants, where he served as a range of clients in healthcare, communications, and the energy sectors on strategic advocacy, business development, targeting marketing, and implementation of lean principles. He also co-founded Raise Your City, a social venture that raised significant funding for DC-based nonprofits by lowering barriers for young DC residents to engage directly in local philanthropic initiatives and events. Well, welcome to you both. As mentioned earlier, we will be having questions and answers at the end of this session. So you can type in your questions. You simply open the question box you see at the right of your screen and type in your questions whenever you'd like to, and I will be asking those of our speakers after they finish their presentation. So Lucy, let's start with you. Tell us a little bit about the project and how you got involved in it.
Okay. Thank you, John, and good afternoon, everyone. Let me just tell you a little bit about how we're going to talk to you this afternoon. We're going to get started by giving you a sense of what Meals on Wheels America was really trying to achieve with its foray into pay-for-success. We want to give you a sense of what the project looked like and highlight the key learnings from the project, but we also want to spend some time talking about how we can be working together to advance and expand outcomes-based financing and to further partnerships between healthcare and community-based organizations to better serve people in need. Next slide, please. Pay for Success is a unique financing model that can enable partnerships between community-based organizations like Meals on Wheels and different kinds of healthcare entities, including Medicare Advantage plans. We're going to give you a little bit more information about how that works in a few minutes, but let me just give you a sense of what motivated Meals on Wheels America to move into the Pay for Success field. First, it's important to note that funding for Meals on Wheels services is woefully inadequate. Older Americans Act funding accounts for about a third of current funding for local programs, and today we're actually serving fewer meals to seniors than we were 10 years ago because the funding has remained basically flat. Programs try to make up for the gap with fundraising campaigns and corporate partnerships, and still programs have waiting lists that are very long, and they're unable to serve millions of seniors who are struggling with hunger and isolation due to lack of resources. Meals on Wheels America is committed to serving and supporting the network of local programs, and one way we seek to do that is to uncover opportunities to drive sustainable revenue to local programs. And as a result, we've had a primary focus on establishing partnerships with healthcare entities. Secondly, we seek to demonstrate the true value of Meals on Wheels compared to other interventions that a Medicare Advantage plan might consider, which makes it possible for local Meals on Wheels programs to compete effectively for contracts with Medicare Advantage plans, particularly as some new opportunities are arising by expanding the types of benefits that Medicare Advantage plans are able to offer. And lastly, we seek to continue to build the data-supported evidence base that demonstrates the impact that Meals on Wheels services have, both on the health outcomes of high-risk, high-need seniors and reducing the utilization of high-cost services, which in turn saves the healthcare system money. Next slide, please. Undertaking a Pay for Success project does require both time and money. So I'd like to just give you a high-level view of how a project can play out and what you need to consider and expect if you were to undertake this kind of a project. Beginning in March 2017, we were fortunate to obtain a grant from the Nonprofits Finance Fund via a Corporation for National Community Service funding, specifically to explore a project with a Medicare Advantage plan. An MA plan to us offered the opportunity for a truly scalable intervention that we could grow over time and could set a precedent and a model for other health plans to follow. By June of 2017, we had established an arrangement with a Medicare Advantage plan that was intrigued enough about the Pay for Success model and saw alignment between what Meals on Wheels was trying to achieve and what they were trying to achieve. So they agreed to work with us to determine whether or not a Pay for Success project would be viable. And so we set to work on defining what would that intervention look like, what would that benefit look like, and how would we measure success. By November of 2017, the Medicare Advantage plan decided that they would formally work to include this project into their bid with the Centers for Medicare and Medicaid Services, which would be due by June of the following year of 2018. So that meant that by December of 2017, we had to get very clear on what was the benefit going to be, where we were going to do it, what was the financial model behind it, how would services be priced, all of the details that will enable the Medicare Advantage plan to prepare for submitting their bid to the Centers for Medicare and Medicaid Services. By April, interestingly, after much internal conversation within the Medicare Advantage plan, they saw such value in the service that we were proposing to offer that they decided that they were able to pay for the benefit directly and to bypass the Pay for Success project. I think this is a really important point because from our perspective, success for this effort was not launching a Pay for Success project. Success for this effort was getting the Medicare Advantage plan to recognize the value and to pay for the services. So for us, this was a complete success. This was the end goal that we were seeking. They went ahead and submitted the bid proposal to CMS in June, In October, they received approval, and in January of this year, we began to deliver service in 3 test markets. So that's a very top-line story of how this played out, but we're going to go in a little bit more detail here as to what that really involved and what it looked like. And to get us started, I'm going to turn over to my colleague, Brendan.
Thank you, Lucy. Next slide. Thank you. So as everyone can see here, the pay for success approach, as Lucy described earlier, was a significant value add to the Medicare Advantage plan in this case. The reason why is because, as many of you may already know, home delivered meals are an existing benefit under the Medicare Advantage structure. Most Medicare Advantage plans around the country are providing some form of home delivered meals to their eligible members. In the case of Meals on Wheels America, for Lucy's earlier comment around their objective to effectively partner with Medicare Advantage plans and serve their members, there was value in a structure that enabled the plan to shift the financial risk of the added cost of Meals on Wheels America above and beyond their existing vendors. Meals on Wheels America, through their More Than a Meal model, offers far more than a home delivered meal. They offer safety checks. They offer social isolation reduction strategies and a number of other value add services at the local level that other meal delivery vendors may not. So by way of partnering with Meals on Wheels, there are a number of additional value add services that can be layered on to the benefit. In order to really demonstrate the enhanced value of these services and the associated return on investment to the health plan, we introduced the concept of pay for success, which enables health plans to shift the financial risk of performance-based contracts to mission-aligned impact investors. A number of you may be familiar with the social impact bond model, or also known as the pay for success model. We've slightly shifted how we structure the model to be more conducive to working in healthcare rather than government, which was initially the partner for which the social impact bond was structured around. So as you'll see through this diagram here, our initial objective was to use the traditional social impact bond structure. But by way of this project, with the health plan, we really learned about some ways to simplify the process and simplify the structure that made sense for all parties. This is really important as more and more health plans are partnering with community-based organizations, and more state Medicaid agencies and the Center for Medicare and Medicaid Services wish to see payment tied to value. The ability to enable community-based organizations to enter into performance-based contracts with health plans will be a growing trend that we see over the coming years. Pay for Success is a way to support the financing of that capacity building on the community-based organization side to enable them to be highly effective partners of the health plan. So our initial vision for this Pay for Success project was for the investors to provide capital to Meals on Wheels America, who would then manage the flow of that investment to their local service providers based on capital requirements to serve the projected volume of members. The local service providers would use that upfront funding to pay for the new and ongoing resources required to provide services to the members of the MA plan. And once specific agreed upon hospital utilization reductions were achieved, the Medicare Advantage plan would repay Meals on Wheels America for those services. Meals on Wheels America would then use that money to repay investors. As you'll see, this differs quite substantially in a couple of key ways from the traditional social impact bond model, namely that the investors in the Medicare Advantage plan would not have a contractual relationship. Why is this important? For Medicare Advantage plans, and this extends to Medicaid managed care organizations as well, compliance rules the day every day. These are risk-averse organizations who have significant business lines focused on serving Medicare and Medicaid lives. So that they really want to make sure that they are offering their benefits and services and paying for them in a compliant way. Being a new type of contracting and financing model, that represents risk. So our ability to change the structure of the traditional social impact bond model to enable an organization like Meals on Wheels America to be the conduit or the intermediary was wise in a lot of ways and got us over some of the perceived risks and perceived barriers to using this type of model. Likewise, we've solved for a couple of other issues inherent in the traditional social impact bond model, namely a need for the payer, in this case the Medicare Advantage plan, to set aside potential future repayments in escrow until outcomes were achieved. That works, that makes sense for governments. For healthcare systems and for healthcare plans, not so much. Under this model, we bypass the need for that. Likewise, under this contract, we also solved for some of the inherent sustainability issues of the social impact bond model by developing a simple performance-based contract between vendor and plan. Through this model, the investors can be repaid throughout the course of the project and go away after being repaid, allowing the community-based organization and the plan to continue in a sustained payment relationship. Next slide, please. We have some key learnings. And the report that we authored through the support of the Nonprofit Finance Fund and CNCS is available on both of our websites. We recommend everybody go and read it. But here we're going to highlight a few of the key learnings from this process. We believe these are applicable not just for organizations structuring pay-for-success projects, but frankly for any community-based organization or network of CBOs attempting to partner with the traditional healthcare system. Key learning number one really focuses around this financing model in Medicare Advantage. As John mentioned, this was the first attempt in the history of the world to structure a pay-for-success transaction in Medicare Advantage. So, as with any time you're doing something for the first time ever, there will be some learnings. First off, knowing the Medicare Advantage bid cycle is incredibly important. As I mentioned, these are highly regulated organizations who have a highly structured way of doing business. Medicare Advantage, there's a requirement to submit annual bids to the Centers for Medicare and Medicaid Services for their contracts. It stipulates where they'll be providing services and what benefits will be included in their package of services to members, as well as the pricing of the premiums for their members. CMS approves these bids on a standard timeline as well. So in our case, we likely entered into the conversations with the plan at the wrong time, to no fault of our own. We were very excited about securing the partnership with this plan, but by the time that we were able to work through all of the conversations and decisions needed to enable us to enter into their bid for the 2019 plan year, we were likely a little bit too late. So one of our key learnings and recommendations to you all and to the grantees with whom you partner is begin conversations about 18 months before the expected service delivery date. So starting a conversation in August of 2019 will prepare you for a bid submission in June of 2020 for a January start date in 2021. This seems like a lot of time in advance, but with these Medicare Advantage plans, That is their structure, that is their timeline, and especially if it's a new partnership, it will take some time to get to the point of comfortability of inserting you into their bid and moving along. So start early in all of these conversations. Key learning number 2, simplify. Especially when working with your first several healthcare clients, always keep things simple. In large part, we transitioned from the traditional social impact bond or pay for success structure to this more nimble performance contracting approach without sacrificing value, which kept the door open for pay for success. But it was in response to our recognition that you can keep things simple for the plan, things will move faster, you have a higher likelihood of resulting in a contract. What this doesn't mean is that the community-based organization has no negotiating power. If you're at this point of the conversation with a health plan, they want to partner with you and they're looking for a way to make it happen that makes financial sense for both parties. Ensure that they're providing you or the organizations with whom you partner with what is needed to make the case for sustained investment. This often means data, right? A lot of these projects, if they're not financed through a pay for success mechanism, will likely be some combination of grant dollars or some type of limited flexible spending from their administrative side of the health plan. So the desire is to prove the value, prove the return on investment in years 1 and years 2, and scale. But in order to determine if the plan is making a wise business decision to scale the service, data is needed. That should not reside solely within the plan. Fight tooth and nail to get control over some of that data and to have it shared back with you so that you can understand where the value is that you're providing, how you're doing, how you can adjust course to improve your outcomes, and ultimately work to build the business case for why that plan should sustainably invest in you. We also realize there are some barriers inherent to the pay for success structure in Medicare Advantage that, frankly, we would not have understood if we had not just jumped in and attempted to structure this first pay for success project in Medicare Advantage. There's no better way to learn than just by doing. And through that process, a couple of key potential barriers arose that we think are important to mention here. First, securing financing on the bid timeline. What do we mean by that? If the bid is submitted in June, CMS approves in October, and services are required to begin in January, there may be some complications with pursuing and securing investor financing to enable the CBO to stand up their service in time for that January start date. If the investor wants some certainty that the contract is in place, they will not receive that until October when CMS approves the bid. That leaves about 2.5 months to engage investors, negotiate terms, and secure that investment to enable you to have the capital to meet the increased demand via that partnership with the health plan. We don't think this is insurmountable. We think that you can engage investors earlier on to get them up the learning curve about you and your project in advance of the CMS decision date so that they're responding to a different set of decisions in October and November, and you're able to kind of secure that financing in Q4, enabling you to ramp up and get started in Q1. The last barrier that we recognize that could be quite substantial is what happens if the increased value of the service, in this case the more than a meal model, is factored in to the pricing of the Medicare Advantage member premium. So the member is paying more because the package of services that they're getting is of a greater value. This is how it's generally priced. But what happens if the outcomes associated with the pay for success transaction are not achieved, and therefore the Medicare Advantage plan does not have to pay? In effect, they've essentially increased the value of the member premium without having to pay anything themselves. This was viewed as potentially an area in which CMS would want to weigh in on, and one of our recommendations is that those conversations with CMS continue and we get some clarity on how to potentially structure that to not unnecessarily penalize the member if the plan itself isn't having to pay. Next slide, please. Key learning number 2, make it easy for the plan to say yes. These are plans that have a lot going on, hundreds of vendors and conversations with them, all trying to relay their value proposition. And the plan has to quickly make some decisions as to whom they're going to partner with and to what scale. Make it easy for them to say yes. A few areas we think are important to do so, which Meals on Wheels really came prepared for in this case, which enabled us to be successful. First, know your audience. Understand the Medicare Advantage plans market, their regulatory constraints and enablers, and how they generally contract. If you've never worked with a Medicare Advantage plan before, talk to other organizations that they've had. Learn about their experience. Learn about some of the barriers they ran into. But come with an understanding of the timelines where they'll make decisions, what they can pay for, what they can't pay for, and how they generally like to structure contracts with community-based organizations. You don't have to have all those boxes checked, but the more you do, the better off you'll be to really get to the table and have the plans take these organizations seriously and prioritize those conversations. In some cases, you may consider engaging or hiring experts with experience contracting with Medicare Advantage plans. And by the way, this extends to Medicaid plans as well. To support your preparation, you may only get one shot. So getting it right the first time is very important. Come with a business case. Every organization is at a different point in their kind of life cycle of really having a strong evidence base and being able to demonstrate outcomes and ROI. Regardless of where you are, come prepared to talk about your business case with an economic model undergirding the effectiveness of your intervention, demonstrating the outcomes and demonstrating the value of those outcomes to the plan. And always show a conservative return on investment. This is very different than how a lot of community-based organizations generally market their value. When speaking with actuaries at Medicare Advantage plans, they're going to take a much more conservative approach to your return on investment than you may have in communicating your value to the broader market. Speak the language of your audience, highlighting the points of value that will most resonate. You know your service best. You know the value and the outcomes that you can generate. Translate that to what Medicare Advantage plans care about. How does this factor into quality scores? How does this factor into star ratings? And ultimately, how do you believe that this service can reduce costs and improve member value? All of those quality metrics and star ratings are publicly available. I strongly recommend, as Meals on Wheels America has done, conducting an exercise where you map your value out to those quality metrics and anchor your conversations with the plans around your points of value in a way that will resonate with them. Price your services creatively to capture the full value to the plan, the members, the providers, the community, and the state. Force the plan to think about the holistic look at your value. A lot of these plans, while yes, they do care about tangible cost savings, they are competing for market share, and therefore value is viewed in a more holistic way. So while people may tell you, don't focus on the warm and fuzzy, there's a lot of value to that, and really understanding how your value accrues to not just the members served, but to the doctors, how it makes life easier for them, how the outcomes accrue all over the community and the state in which that Medicare Advantage plan is working, will really enable them to be a better competitor in their markets. 3, data readiness. We can't underestimate this. Invest in strong infrastructure to protect patient data and information that the plan shares. This is one of the largest barriers and the greatest areas of discomfort that plans may have in partnering with CBOs, which is the real and perceived risk that data sharing at the CBO level may result in some type of breach or lack of compliance, which is costly and dangerous for plans. So demonstrate that you've thought through HIPAA, that you've thought through how to manage patient information and PHI to really get the plans over that mental hurdle. Lastly, to Lucy's point earlier, scale. If you can't serve a plan's entire contract area, and in some cases, contract areas span multiple states, think about developing partnerships or join a network to extend your reach. If you put yourself in the plan's shoes, they would rather partner with one or several vendors than 200 across their contract area for simplicity's sake. So actively explore where are those networks where you can jointly approach plans with a common value and common value proposition. Next slide, please. Lastly, key learning number 3, for my slides at least, I'll pass it off to Lucy. The regulatory realities may conflict with your project objectives. When working with government-sponsored health plans, Medicaid and Medicare, as I mentioned earlier, compliance is so important. And understand that some regulatory constraints may conflict with your objectives. So come to the conversations flexible to adjust to the needs and the realities of the plan. We cannot understate the importance of this. You will not get everything you want out of the relationship, but you can build towards that over time. Focus on establishing a trusted, engaged partner and work towards a partnership in which your total value is recognized and compensated over a number of years. It may not all happen on day one. 2 regulatory realities that we go in much more detail on in our report, but we'll touch on here. Uniformity of benefits. In Medicare Advantage specifically, we have historically seen a model that stipulates that if a benefit is offered to one member, it must be offered to all. There are some exceptions to this rule, but in most cases, the plan wants to see your ability to serve an entire contract area. So this well-intentioned regulation, which, theoretically makes sense, really limits the plan's ability to pilot interventions before taking them to scale and reduces the ability to partner with community-based organizations, many of whom operate locally and don't have the capacity to serve an entire MA contract market, which come back to our recommendation to explore some networks and some partnerships. We are finding that the CMS has updated supplemental benefit guidance to offer some more flexibility here to enable plans to offer supplemental benefits for the chronically ill and target populations depending on their diagnosis and some other factors. This is really, really important. Some of the kind of enhanced benefits that we're seeing in the supplemental benefit guidance are focused on transportation for non-medical needs, home delivered meals beyond the current allowable limit, and other kind of food insecurity interventions. A large number of the plans who submitted some of these supplemental benefits in their 2019 bids focus on these areas. As 2020 and 2021 bids come along, we're going to see that expand beyond transportation and food insecurity to some other areas of non-medical, non-clinical benefits. Keep your eye on that and actively explore how your type of solution can fit into that supplemental benefit guidance. And the annual bid cycle is the second kind of regulatory reality that we'll keep coming back to. With the annual bid cycle, there is project and investment risk in the pay-for-success model. Most pay-for-success projects span multiple years. The annual bid cycle requires that the MA plan every single year rebid for a contract. During that time, the MA plan may decide not to rebid. It may not be awarded the bid, or significant regulatory changes could occur that represent project and investment risk. So that's something that we're actively exploring and researching. how potentially we can shorten the timeline of pay for success projects to fit within that annual bid year. And in cases where that's not possible because outcomes take longer to accrue, exploring that conversation with CMS as to how we can provide some certainty around future payment. And implementation delay. One of the key areas that is really important to be mindful of in beginning conversations with MA plans is if you don't have your project mostly defined by March or April, you won't be able to get into the following year's bid. So really making sure you're mindful of the calendar, you're starting conversations earlier than you would ever envision would be needed is the best course of action to ensure that by the time that the plan is wrapping up their bid internally in March and April for a June submission, that you're not left behind and your project isn't unnecessarily delayed another calendar year. Lucy.
Thank you, Brendan. Next slide, please. As you think about how you might engage or support a Pay for Success project with the Medicare Advantage plan, there are clear pros and cons to consider depending on the size and structure of the Medicare Advantage plan. So I'm going to spend a little bit of time going through each of these. Let's start with the larger plans. The pros for working with a larger plan. Regional and national payers have the capacity to scale successful interventions across large populations. And for service providers with regional or national growth ambitions, like Meals on Wheels, this is a very important factor. It has that scalability opportunity that we're looking for. But for every upside, there is a downside. For these largest payers, it can be difficult to convince them that it's worth the time and resources to structure a project that at least initially will only serve a small number or a small portion of their enrollees. Another pro, large payers will have the significant financial resources to commit to the initiative, but for some payers, they may not view the prospect of supporting capital from a third-party investor as particularly enticing because they have deeper pockets. But there are other benefits to Pay for Success that are of interest to them, like paying for outcomes, which I think still apply. Larger payers have more employees and more likely to have the personnel with the skills and the time to plan, design, and implement a project like Pay for Success. They need to interface across departments. There are complexities that have to be worked through from a financial perspective. Like any new project, there'll be a learning curve, and so it will be resource intensive for a time as people get up the learning curve, but a larger plan will be more likely to be able to support that kind of a new effort. And while data sophistication is not necessarily tied to the size of the plan, some of the largest health plans are the most sophisticated when it comes to data analysis. With Pay for Success projects being so heavily dependent on modeling projected success, a plan's ability to rapidly pull together accurate and complete data will definitely expedite the project structuring. So let's talk about cons of working with a larger Medicare Advantage plan. The flip side of a larger payer's significant resources is that there are often parts of the company that operate in silos or in different physical locations. And for a plan's first Pay for Success project, they will need to probably get input and buy-in from executives, from finance, from legal, from compliance, from quality, from community benefit, from actuaries. The amount of time that it takes to educate all these different players, to get them working together, to get input and support at various points in the large and complex organization can definitely slow down a Pay for Success project. And with so many players, any one project champion may have less ability to really influence the outcome of a Pay for Success project. Larger payers with significant business lines in government-sponsored healthcare like Medicaid and Medicare are naturally risk-averse. Brendan spoke a little bit earlier about all of the compliance rules and requirements associated with operating in that environment. And that will be the priority, which may cause them to not be as interested in taking the risks that could be associated with a Pay for Success project. Let's look a little bit at the smaller plans. On the pro side, with fewer resources, the promise of tapping into a new stream of capital coming from outside the organization to support an underfunded initiative, a population health initiative or prevention initiative, can be very enticing. So the value proposition for pay for success could be even stronger for a smaller Medicare Advantage plan that doesn't have all the resources that a larger plan may have. In a small plan, the executives are likely to know who to work with, less organizational structure to engage with, easier to get to decisions because there aren't as many people involved, and so you can definitely expedite a project. With most small plans, seeking to seize market share from the larger plans is a serious objective, and that can be a real enticement for them, and they may be more interested and willing to take on an innovative and risk-based kinds of initiative in order to try to penetrate a bigger market share. On the con side, because they're smaller, they have less bandwidth to support multiple strategic initiatives. And at any time, they can decide that one strategic priority trumps another strategic priority and decide that they're not going to move forward with the Pay for Success project. There's rarely an excess of resources to tap into for multiple projects, and so it leads these plans to be more selective in deciding what they're going to take on at any one time, since they have a smaller number of staff to allocate. Smaller plans are operating in one or several geographies may lack the scale that some service providers would like to have. So, for example, if they're within just a single state or even a portion of a state, that may not be as appealing to a service provider that's seeking to have regional or national impact. And small plans with limited resources often, not necessarily, but often will lack the data sophistication that the larger plans are able to invest in. So when targeting geographies and enrollees based upon specific disease states or health status, being able to access complete data sets and do rapid analytics is really important in a Pay for Success project, and that not having that talent or competency can definitely delay a project. So those are some of the pros and cons if you're thinking about supporting a Pay for Success project that's really tied to the size of a Medicare Advantage plan. Next slide, please. Before we move into questions, I just want to build on some of the learnings and suggestions that Brendan started to offer for advancing this whole field of outcomes-based financing and Pay for Success. There are definitely opportunities for philanthropic support to enable these kinds of projects to move forward, particularly those with a focus on building partnerships between community-based organizations and healthcare organizations. Not only is there an opportunity to support the planning phase, which we call it transaction structuring, there are many pieces to these projects in designing them and tapping into the right kind of expertise to do the financial modeling, to building the evaluations that will assess whether or not the outcomes were actually achieved and warrant repayment to an investor. All of those things come with price tags. And in addition, the world of community-based organizations is in, I would say, a state of transition at this point. They see the opportunity, there is variation in terms of their readiness, and there's a real opportunity for philanthropic organizations to support the capacity and capability building of local community-based organizations to be able to partner effectively with healthcare entities. As Brendan indicated, the role that the Center for Medicare and Medicaid Services play is very important. And there's opportunity for all of us who are interested in addressing social determinants of health and trying to really create solutions outside the traditional healthcare system to work with the Centers of Medicare and Medicaid Services to co-create solutions that can overcome some of the barriers that would make it more feasible for Medicare Advantage plans to engage in this work and to look at different ways that they can support these kinds of services. And finally, I think, and not unrelated to that, is there's an opportunity to play at the federal and state levels. Right now, there's a lot of focus on social determinants of health, but the reality is there is no systematic way to pay for the services that have the greatest impact on social determinants of health. And I think that's an opportunity for all of us to work together to raise awareness of that fact and to help brainstorm and test different kinds of solutions that can help us break through on that. So I will stop there, and I'm going to turn it back to John to take us into the question and answer period.
Well, thank you, both Brendan and Lucy, for the wonderful presentation. And we are going to move to questions at this point. Just as a reminder, you can still type in your questions for our speakers today. You just go to the question box that you see on your screen and open that up, and then type your question, and I will ask the speakers at this point. So I'm going to shoot this one to Brendan first, but Lucy, certainly you can respond as well. But the question is, in terms of readiness, and you talked a great deal about readiness and the factors that were involved in that. In terms of readiness, how much do you find that the community-based organizations or CBOs are ready to meet the Medicare Advantage plans, compliance and security requirements? So I think a comment in general would be helpful, but then specifically around privacy and security issues that go with this.
Yeah, great question. I would say not often. And the difference between a community-based organization's perception of their readiness and the health plan's perception of the CBO's readiness can be pretty far apart. So I would say that a lot of CBOs we're seeing are taking steps in the right direction. But in many cases, it does require significant investment and significant in-house capacity, right? This isn't just purchasing a software tool. It's having the kind of legal structure and processes and procedures in place to manage data and to adequately respond if and when a breach does occur. And so we are seeing, real value in network partnerships where the network aggregator can take on some of that responsibility to limit the need for the CBO, especially those at the local level who don't have large number of resources, to take on some of those responsibilities, not just for security, but for managing billing, for managing quality and outcomes reporting, and ultimately managing the referral of members. A number of these aggregators are, I would say, starting to pop up around the country, focused on being that conduit between health plans, health systems, and networks of community-based organizations. Without going into too much detail on who some of those are, I would recommend that, especially for the smaller CBOs out there who don't have the resources to make those upfront investments in their own infrastructure, to begin exploring partnerships with aggregators and networks out there who can take some of that risk on.
So, John, I would like to add on, if that's okay. From the Meals on Wheels perspective, I would say that the network at the local level is well aware and understands and is well along the road to building the kinds of infrastructure and capability that is required to partner with healthcare. And they're doing it all the time, every day across the country. We at Meals on Wheels America have a very robust member readiness strategy. We've been fortunate to have support from partners like West Health Institute and the Gary and Mary West Foundation to build different kinds of education and training opportunities. We have partnerships that help to get folks on a common data infrastructure platform. So there's a great deal of work that's going on. And I would say that Meals on Wheels programs are probably in the forefront of community-based organizations to build that capacity.
Well, that leads to another question in a sort of similar vein. The question about whether or not this is simply beyond the capacity of of most CBOs, particularly at the local level. And I think it's also true, I would add the additional question, whether it's beyond the capacity of funders at the local level. So is this something that has to really be at a national organizational level to be successful, or are there things that you could take from these learnings and apply at the local level as well? I'll open that with you, Lucy.
Okay, I think that there's definitely an advantage to approaching this from a national or at least a regional and state level, particularly given some of the partners that we're targeting. They are national and regional, right? And so they're looking for solutions that are going to work across geographic boundaries. So to the extent that we can have a network focus as we build these capabilities and, and capacity, I think that's an advantage. But that does not preclude the opportunity for state and local foundations to support that kind of capacity and capability building, because there's enough work to go around that I think, much like we're taking the network approach from the community-based organization perspective, there can be a network approach from from a foundation supporting perspective as well.
Brandon,
I would echo that. I don't think it can be out of reach. That is not a possibility. We need to have CBOs at the local level, because at the end of the day, health happens at the local level. We need CBOs at the local level who may not have a need to operate at scale or nationally to be effective partners of the traditional healthcare system. Increasingly, healthcare systems and health plans are recognizing this need. We, as CBOs, really need to meet those plans where they are and help those CBOs become more effective partners. Help the health plans and health systems be more effective partners of the CBOs. It's not a one-way road. So I think there's a tremendous opportunity to continue building local infrastructure and local capacity to enable your CBOs to be effective partners of healthcare systems and health plans. I see no greater value that philanthropic foundations can provide, and building off of some of the really promising work we've seen to date, such as the SCAN Foundation's Linkage Lab efforts. These are really important use cases and models to help CBOs develop these relationships and actually be successful and sustain them.
Well, just time for one or two more questions. Lucy, you talked a little bit about the role of social determinants of health here. Would you expand a little bit more on that, on how you see this particular project fitting into that model? Are there specific social determinants of health you're looking at particularly?
Yeah, that's a great question, John. For us, it's fortuitous that there is currently such recognition of the impact of social determinants of health on overall health and well-being, and how that relates to use of the healthcare system, and particularly among high-risk, high-need populations. For organizations like Meals on Wheels, we've been in the social determinants of health business for 50 years. And it's not just around food insecurity. It's around things like social isolation, where I think there's increasing recognition of the detrimental effects of social isolation on health and well-being. It's around living in an environment that's safe, and that any hazards are being removed to eliminate the risk of falls, which is costing the nation's healthcare system $50 billion. It's addressing things like malnutrition. It's connecting seniors to other services to address things like transportation. So I think social determinants of health is what community-based organizations do. That's their reason for being, and I think that means there's tremendous opportunity now to make those connections, because healthcare is recognizing that, and they're trying to figure out how to leverage community-based organizations to help them fill out that piece of what they do, so that they can reduce the healthcare costs and improve health outcomes.
Well, thanks. So I'll ask you one quick informational thing, and then we'll move to your final comments. So could you remind us where people can get this report that has just come out from this project?
This report
you can certainly
is
find it
available.
on Sorry, Lucy, go ahead.
Go ahead. Okay, we were probably going to say the same thing. So go ahead, Brendan.
It is available on Quantified Ventures website, quantifiedventures.com, under services and case studies.
Okay.
And it's on Meals. It's also on the mealsonwheelsamerica.org site as well, and you will find that on our research page.
Oh, wonderful. So at this point, I would like to turn back to you for your final comments for our audience. Brendan, we'll start with you.
Thank you. For the funders out there, this world of connecting CBOs and payers is absolutely critical, and there will be amazing, great work ahead and a lot of work ahead over the coming years. Aside from the kind of infrastructure capacity building support that CBOs really need to prepare and be effective partners of health systems and health plans, there is just as much of a need to focus in on how these services are being paid for, and ensuring that we're not simply providing more demand to CBOs who are already capacity constrained. Tools like Pay for Success solve for that, and they're critical. Every CBO we speak with understands the value of this type of financing model, really as a way to get over some of the very real barriers they've encountered, even if they are successful in striking a partnership with a health system or health plan. They don't have the money to serve that increased volume, right? So funders, I really do believe, have an ability to be a catalytic source of capital to move this field of pay for success and outcomes-based financing forward. Helping to really get some of these projects off the ground to demonstrate the value of this type of contracting and financing approach in Medicare Advantage, in duals plans, at the community hospital level even. We need to see more of these projects, and we need to see these projects ultimately be successful, and it takes investment on the front end to do so. I think there's a tremendous opportunity for the organizations listening in today to really think about themselves as catalytic sources of this capital to move the field of performance contracting and outcomes-based financing forward at the community-based organization level. Thank you.
Thanks. Lucy?
Yeah, thanks. And, I echo everything that Brendan said, and I guess I would add a little bit to that. Definitely time to really look at how we invest in the community-based infrastructure in this country. I think that's a huge opportunity, and it is the only way we're going to break through on social determinants of health. That would be one area of support. The second area I would urge people to think about is collecting and the data that's necessary to demonstrate the true impact on health outcomes and corresponding utilization of high-cost healthcare services. At the end of the day, that's what healthcare is looking to figure out. They need to figure out how to reduce the cost of care. And anything that we can do from a research perspective, from a pilot project perspective, to collect that data and prove that point, I think would be ripe and timely. And the third piece I would say is this is a unique time where I think there's a real opportunity for some innovative testing on different kinds of solutions to address social determinants of health. We're doing some work now on, what is the most effective way to reduce the sense of isolation and loneliness among homebound seniors, because nobody's really done that yet. So I think there are tremendous opportunities to think creatively about some innovative interventions and to get out there and test them and try them and then share those learnings with the field. So I will stop there and thank John and Grantmakers in Aging for this opportunity.
Well, I want to thank Lucy Teilheimer and Brendan O'Connor for this wonderful presentation today. Congratulations on the project so far and all the great work you're doing, and thank you for sharing it with us. I also want to thank the John A. Hartford Foundation for their support of this webinar and all of our webinar series. We do make this presentation available, both the audio and the slides, to anyone who wishes to view it later. Please watch an email to be sent to you within the next few days, or it'll be up on our website. Please join us again for our next webinar on April the 2nd at 2 p.m. Eastern Time, which will be on the Blueprint for Complex Care, Opportunities for Philanthropy in Healthcare and Social Services. This is a webinar offered in partnership with Grantmakers in Health, and it will showcase the recently released Blueprint for Complex Care, which details steps for further developing a wide range of efforts aimed at improving the lives of people with complex health and social needs and advancing the field of complex care. You can register for free, as always, on our website. And finally, I want to thank all of you for participating in today's webinar. Have a great day.